about the scapula on page 260. And what's good about this is we've already talked a lot about the scapula. Why? So we know the parts of the scapula. One of your test questions, your quiz questions today was, what forms the Y? Did you get it right? Anterior was what? Coracoid. Posterior was the acromion, and the leg of the Y is the body. Very good. So we should be okay with that. So let's start talking about the AP on page 260. Here's some pictures of her doing. We definitely can do them what? Standing, or you can do it supine. This here, again, I would say it's easier positioning when they're standing. When they're lying down, it's table movement, or you're going to have to be moving and shifting the patient physically. So I usually try to do mine standing. It does say the upright position is usually more comfortable for the patient. We've heard that in just about everything we've done with the shoulder. So we know the preferred is most comfortable and easier to position, right? All right, so position apart on page 260. I got her 1 through 9s on. Oh my God, let's see. It says abduct the arm to a right angle with the body to draw the scapula. What? Lateral. That's what you're trying to do. So this here pulls the scapula out to the side, taking it away from the vertebral column area. So you want to pull it laterally. So you really want to get there and do this. And you can feel it when we get lateral. We'll do that, and you can feel your scapula actually pulling out. And the reason I'm putting emphasis on that, guess what that is? Yep. All right. This projection, do not rotate the body towards the affected side, because the resultant obliquity would offset the effect of drawing the scapula laterally. Remember I told you when you're standing there, your body is actually in a what? Either side is in an oblique position. The only thing that's in contact to the IR behind me is going to be my spine. So you already have this going on. It's telling you, don't do this, because it's going to take away what you just tried to do with this type of movement. Okay, so they're telling you, don't rotate the patient. Leave them straight. Position the top of the IR 2 inches above the top of the shoulder. Make the respiration during slow breathing to obliterate lung detail. That's a new one for you. So would you think that's a potential test question? Have you seen that before? Slow breathing. It didn't say fast breathing. That would be a breathing technique. It says slow breathing, shallow breathing. And to obliterate, what's the word obliterate? Blur. Make them no longer visible, so they kind of disappear. All right. Your central ray is perpendicular to the mid-scapular area at a point approximately 2 inches inferior from the what? Coracoid. What's the shoulder? 1. So now we're going to drop down 1 more inch, and we're going to get the entire scapula through the lung field, right? Because we have the chest, and then we have the scapula in the back. So that little bit of movement that we're going to allow happen, hopefully we'll blur that out, and you'll see a pretty picture of the scapula. They're not very pretty images, I will tell you this. So I'm going to show you one of them. See how it looks right here? Can you see it? This is what border? Oh, my pointer never on. All right, so let's see how I remember to do this. Pointer on. Pointer on now. All right, what's this? That's the vertebral or the medial. All right. You see what's this? Inferior angle of the scapula, right? And here it goes up here. And there, what's this? What's this? Yeah. What's this? See that projection right there? What's projecting forward? That's what you palpate when you push underneath the clavicle. All right, and here's your what? This is the outside border called the what? Axillary, yeah, or Lateral, yeah. So they're not very pretty. They're hard to see. In our digital world, they're a little more where we can do with some windowing and make it come into view. So the lungs are definitely obliterated, but unfortunately we can't get rid of what? The ribs. The ribs are going to be there, so they're always going to be superimposed in it. So it is hard to see them. And I think they rely more so on the scapula Y to see if there's really any fractures or anything, because it really does pull it away. But you can certainly see that it is pulled laterally way over here and away from the spine, because your lateral borders, your medial borders are very close to the spine. So they did a good job. And the trick to this is when you're seeing this on image critique, find the humerus. And you know the humerus is what? It's shooting out this way. So that should help lead you into that. And I think this would be the only one that looks similar to a what? Chest x-ray. Now you're going to see this. This is the clavicle. We're going to be talking about it in a minute. If this were a clavicle, where would it be at? What did I tell you the first thing to do on image critique? Crosshair it and find where the central ray went. That's your answer. Here's the coracoid. I went down 2 inches. Isn't that where the book told you to enter? That's how you do image critique. You find out where the central ray is by crosshairing the image. I just did it. I went down and I went this way. I said it's somewhere right in here. So it's not a clavicle. Clavicle is way up here. If it was a clavicle, wouldn't the clavicle be in the center of the picture? So don't get confused with this stuff. It's easy if you keep it easy. Crosshair every image you look at and say, well, I know the central ray is going wherever your central ray is, your crosshair is at. Because supposing that's where we're supposed to be at, putting our central ray. Center of the picture equals center of the what? Central ray. So that answers one question for you, helping you to determine what you're looking at. Does that help you out? Does that make sense? That's the first thing I do with every image. I cross it, find the center. I say, well, it can't be this, it can't be this. What's center to the picture? The scapula. There's the answer. Well, is it a lateral or is it an AP? Has to be an AP. The whole thing's there. Does that help you understand image evaluation, image critique? Yes, first thing you're going to do is that. Don't call it a clavicle, but there's the clavicle. Because you're going to get confused, but when we're looking at clavicles, you'll see it's just a long skinny. Look at your collimation. Collimation helps you out. What do I know that's in that area that large? All right. And we have the slow breathing. That was unique. First time we've heard that. So you know you're going to see that again somewhere. Somewhere she's going to have that either on image critique or she'll have it as a test question. Anything that stands out that's new to you, unusual, you've never heard of it before, or if you see the word what? Profile, you know you're looking at potential test questions. Registry questions, the more important part of it. All right. So here's your evaluation. You have the acromion, you have your clavicle, there's your coracoid, glenoid cavity. You have the lateral, medial borders, and the inferior angle. And I told you that inferior angle of the scapula becomes very important. What does it correlate with as far as the spine? I told y'all this Tuesday. What number? T7. You'll use that for all kinds of stuff. So get used to understanding when I'm feeling that bottom corner of the scapula, I'm actually at T7. You're going to use it for chest x-rays. I mean, there's just a ton of stuff that we're going to use it for. So just get that in your head. That is T7. Inferior angle of the scapula. Right there. All right. Enough on the scapula, I think. What do y'all think? We're good? Do we need this? Anybody need me to read that to you? All right. All right, there's a posterior view. Do we need that? No. All right. Do we need that? I think we had this in I looked at this on Tuesday with y'all. Make sure you know the borders. There are 3 of them. It's a triangular bone. The scapula is a flat bone. It's not a long bone. So that might be a classification thing you might want to look into. More pictures of it. More pictures of it. So PA versus AP for a lateral scapula. Can you do them AP or PA? Yes, you can. Someone asked me an email about this. In your book under scapula Y for shoulder joint, there's one little statement. It says, this can be done AP if trauma warrants it. There's one line. And the only thing different, I can't say the only thing different, is what? The PA, you're shooting side, what? Here's the IR, side down, PA, right? Here it is AP, and the shoulder is what? Side away. It's pulled away from it. That's the only difference between the two of them. Yes, your collimation stays the same. Yes, your central ray stays the same. But you're looking at it from the anterior aspect versus the posterior aspect. So it's technically the same position. It's just that you're turning the patient in the opposite direction, which is what you do in radiology. Anything you can do what? AP, you can do PA, but you have to flip everything. If it was demonstrated AP down, it will be demonstrated PA up. If it had an up angle AP, it has a down angle PA. You flip everything and it comes out to be the same image. So yes, you can do AP or PA, just with everything. But what we try to do is minimize. What's the problem with the AP? What do we have right here? Yeah. That OID is going to maggot some. But if this is trauma and that patient's on the table, who cares? You're looking to see if this is really fractured. If there's something major going on, you can get it the perfect PA, RAO, whatever it's going to be. You can do that later once he's been cleared. But right now, we're trying to get as many images as we can on that stretcher, that trauma stretcher. So know that you can do a lot of this AP, even though you were taught PA. And we have we have lots of trauma labs coming up in your second positioning class. All right, scapular analysis. The lateral and vertebral borders of the scapula are demonstrated without superimposition. This is telling you this is a problem here. Can you see this is what border? That's that thick one, right? Is that the lateral or the medial? The lateral, all right? And this is that's your thin one, right? And remember that article I gave you? Did y'all read it? All right. Doesn't it talk about this? That you'll see the thin one as a single line, and then you're going to see the thicker one here. So what is it telling you here right now? The patient is what? They're over rotated because the thick border is closer to the what? Spine than the thin one. So this is decrease your patient, they're over rotated. The lateral scapular borders are demonstrated next to the ribs. The patient was rotated more than needed to superimpose the borders of the scapula. That's the analysis and how to correct it. Now, let me ask you this. Is this going to stand true for an AP? It's going to be the opposite. It's going to be the opposite. This is only true for what? PA. So it's going to be the opposite. So you'll have to remember that if you're doing APs, you guys will get good at AP scapula wise because we do them all day long. We do them. Everybody at RPs does them AP. So you get used to it. But your analysis here is for the PA. So if we did it AP, the opposite borders would be the two that you want to change. So you'll have to remember that. Because it's good to know this because when you've done one and they're not superimposed and we're going to let you go back in and repeat it, your first question is what? Which way do I correct him? Which way do I increase him more or less? So you'll be able to know looking at the two borders of the scapula, right? Hopefully. All right. Lateral scapula. All right. So we did the AP. No problem. 2 inches below the what? Coracoid. Slow breathing too. Obliterate the lung field, right? I always say do the howl, the howl, you know how Indians howl? So they do bring the arm up at real high to do what? To pulling the scapula lateral, all right? We did the scapula Y for shoulder joint, yes. And we said that the position of the arm was irrelevant because what didn't change? Lillian, you know this. What doesn't change, Zoria? When we're doing scapula Y for shoulder, what doesn't change with the movement of the arm?
The scapula Y doesn't change, right? Like the...
Come on, I drew this in y'all's head. Who else was with Chelsea?
The view doesn't change?
I'm sorry?
The view?
The view, is that what you said? Zoria, don't let me down.
I'm sorry.
Come on, that was 45 minutes of my day.
One more time.
What didn't change when we were doing scapula Y for shoulder joint? We didn't care where it was because something didn't change. And it specifically tells you this in the book about 3 times. My arm hanging down, it's still right over what? Where it's supposed to be, the glenoid cavity. My arm straight up in the air, my humeral head is still where? My arm pointing straight out in front of me, where's the humeral head? What doesn't change with the placement of the arm? The relationship of the humeral head to the what? That was for scapula Y for shoulder joint. If my humeral head is not over the glenoid cavity, what do I have? A dislocated shoulder. That's why you're doing it. Lillian, you owe me 2 pieces of artwork now to even get back in my graces. Goodness, Zoria, Chelsea, I coached you into this. All right, so now we're at the lateral scapula. Guess what becomes important? The arm placement. That's the 2 differences. Yes, it looks very similar to a scapula Y, but we have to pay attention to where the arm is going to go because we're going to either be looking at the processes of the scapula or we're going to be looking at the body. So we have to get the arm out of the way for whatever part of the scapula we're trying to demonstrate. I think that's what the article talked about. I think that's what that question was leading to. This is not your first time to hear all this, I hope. All right, so let's go on here. So this is a lateral scapula. Looks very similar to the what? RAO. But look where his arm is at. His arm is in the what? Behind him. This is on page 262. RAO, LAO. But what is he doing unique about the arm? Putting it behind his back. So that tells you the humeral shaft is going to be superimposing the body. What's up here on the top? Your 2 processes are cleared of the humeral shaft and the humeral head. So this is the lateral for the processes. Everybody get that? All right. Page 262. I've got the whole page highlighted here. Upright standing. This is column 1. The prone position can be used. I would not advise you to lay a patient down to get this because you could easily do this on an AP easily. Adjust the RAO or LAO with the affected scapula center. Average range is 45 to 60. I think the article debated that and said that the 45 normally will get this. Oriented the plane through the superior angle of the scapula, the acromion perpendicular to the IR. For delineation of the acromion and the coracoid process, this is important. Bottom of the first column. Flex the elbow and place the back of the hand on the posterior thorax at a level sufficient to prevent the humerus from overlapping the scapula. To show the body, the scapula, ask the patient to extend the arm upward and rests on the forearm on the head. So one's going to have the arm down, one's going to have the arm up. All right. After placing the arm in any of these positions, grasp the lateral and medial borders. We did this in lab. I told you to claw that medial border, put your fingers in and start turning them until your hand goes where? Vertical to the IR. And you got them in perfect positioning. Make my final adjustments, placing the body of the scapula perpendicular, respiration, suspend. What's the word suspend mean? Stop. It doesn't say take a deep breath in. It doesn't say blow it out. It just says what? Stop. So I would say stop breathing instead of what? Suspend. Is the patient going to know what that means? Most people, layman people, know that radiologists, they want you to take in a deep breath because they probably have had a what? Chest x-ray. They think everything in radiology requires you to take in a big, big, deep breath. So unless you explain suspend to them, say, I'm going to tell you to stop breathing wherever you're at. Just stop for a split second so I can take my picture. Otherwise, they're going to want to take in the deep breath. That's just, I think it's handed down from generation to generation. Even the kids come in and you're doing a foot and they want to take in a deep breath. So anyway, all right. Perpendicular to the mid-medial border of the protruding scapula is your central ray. Midpoint of the protruding, and you'll be able to feel it because when you place your arm on the posterior thorax, it pops out. So you'll feel it real good. You can go find the middle of it, shoot straight through it. Collimation, it says filled to 12 inches, 1.5 inches above, and 1 inch beyond the lateral shadow. Collimation, you know, I hate all this. I just was not taught this way. I was taught what? As close as possible. It makes a beautiful picture. Don't clip anything. All right. Evaluation criteria. Lateral and medial superior borders are superimposed. No superimposition of the scapular body on the ribs. No superimposition of the humors on the area of interest. Inclusion of the acromion and inferior angles. So let's look at some of these here. Lateral evaluation criteria. Okay, this is a lateral scapula with the arm where? Can you see how it's going to be bent down like that? So it's going at your push to get that angle that they're asking for. It's placed on the posterior side. Can you see how this arm is what? Pulled over. Here's the head. The humeral shaft's going this way. That's how you do image analysis. Find the what? The one thing that you're moving around is the what? The arm, the humerus. So find it. Here it is. I see a Y, but I also see the arm going out. So what gets me there? This gets me there, right? Placing the hand on the back of my thorax, I get my humerus going in that direction. So that tells me I'm going to be shooting it for the what? It's cleared the processes. It's over. It's down towards the body, right? So it's not crossing over the processes. Here it's doing what? It's crossing over the processes. There's the humeral head. Follow the shaft. Follow it off the image. Put your arm there. That tells you you're clearing what? The body. So that humerus, that arm is your friend in image critique. Just about everything we're doing, it is. So look at what you're doing here. And then I'm going to do this. On this image here, I'm going what? I'm crosshairing and I'm hitting right there. What does that tell me I'm doing? A scapula, and it's probably for what? The body. There's the body right there, right? Okay. Here we got what? The arm's going what? Straight up over their head. So what's it cleared? Yeah. So they're really telling you can do what? Grasp the opposite shoulder. Getting this arm over like this works. Or you can get them to do this. A lot of people can't stretch their arm on top of their head. Get an 81-year-old grandma in there and tell her that she has to put the top of her arm on top of her head, and she's going to look like you're crazy because her little shoulders are all arthritic. So this is a better way of doing it, putting it just over the top of the thorax. All right. Any questions on this? This is the scapula. We did the AP. We did the scapula for lateral scapula for processes, lateral scapula for body. Any question? Which one was to obliterate lung field? Look at it, look at it. AP scapula, the only thing that's gonna be behind, underneath the lungs. That's the only thing we talked about, right? All right. Next, we're gonna talk about the dear old clavicle. Page 219, guys. Or not. No, that's the anatomy of it. Do we need to see the anatomy of it? It's only a little skinny bone. All right, let me get to the next one. 257, sorry. That's the anatomy portion of it. All right, we did a little bit of this in Lab Tuesday. We saw there were some differences in doing it AP standing. AP standing with a lordotic position, which means what? Leaning back. There's a difference between if the patient is going to be able to do leaning back, lordotic position, which is very hard. I don't know if we actually did it. Did we do it? We're going to do it today. We'll let you stand there for a minute or two in a lordotic position. Guess what? It hurts because you're literally resting your whole body on the back of your neck and it hurts. So I usually don't do the lordotic. I just add a little angle to what the requirements are. All right, so on page 257, I'm on position apart. You can do it supine or upright. If the clavicle is being examined for a fracture or a destructive disease, if the patient cannot be placed in the upright, use supine position to reduce the possibility of fragment, displacement, or additional injury. Position of the part, center to the clavicle, midline of the table or vertical grid. Place the arms along the side, just standing real relaxed. Suspend at the end of exhalation, and this is for the AP. That's going to become unique. Exhalation. Because normally you would want us to think, how are our clavicles in our bodies? Are they able to see? Yeah. Your clavicles are like this. They're already at an angle, right? That's natural. So what would you want to do? Take in a deep breath. You want to push those clavicles up, right? So that's what I thought would be the respiration for this one. And yesterday we read it, it says exhalation, okay? So when we're doing the upshot, which will be our next one, that would probably be the one that you're going to want to encourage it. Since you're doing an upshot, the angle is going to pull it up. You're trying to help that out. That's the one you'll probably take in the inspiration. So this is unique here. The AP clavicle is what? Exhalation, right? That's unique. I'm telling you, that's a potential what? Yes. All right. So let me get to back into the book here. Let's see. Perpendicular to the mid shaft. Collimation. It says adjust as needed to include 1.5 inches above the shoulder, 1 inch beyond the lateral aspects of the shoulder and the entire clavicle. My preference, let me show you this image here. My preference is you have this going on. That way you know you have the articular SC joint over here of the opposing clavicle. So there's no question. If you get it right here, midline, and you collimate it, you're getting very, very close to that joint space. And you may question, is it really there or not? So I always go over to the other side just a little bit, just to make sure that it's all on there. All right. What end is this? It's called the what? Sternal extremity. You heard of that before? And this is called the what? Chromial extremity, the two ends. All right. Turning the page. All right, let's go over to the page 258. And that is going to be your AP axial clavicle. This is a it says, if the patient is injured or is unable to assume the lordotic position, this is under the AP axial projection note. Anytime there's a note, you should pay attention to it. It's important. It says, a slightly distorted image results when the tube is angled. An optimal approach for improved spatial resolution is the PA axial projection. So if the patient can't do the lordotic, they're recommending that you flip them around. Now, if they're on a table, you're not going to be able to flip them around, right? They're going to have to overcome the lordotic position. They're not going to be able to do that on the table anyway. So what do you think we're going to do when we do supine? And they can't do lordotic. We're going to angle what? More. We're going to angle more. So what that lordotic brought to us with angulation, we're going to add that to the x-ray tube. So it's going to be a little bit more when we do it on the table. All right, AP axial. It said stand or sit the patient at, with the back against the vertical. Place the patient supine or on the table, and that's if they cannot stand up. Standing lordotic position, have the patient step forward about 1 foot, then lean backward with the position in extreme lordosis. Temporarily support the patient in the lordotic position. Then they can resume the upright position while the equipment is being adjusted. In other words, don't stand them there first thing and leave them hanging there. I'm going to do you guys that in the lab just so you feel it. After about 2 minutes, you'll understand why. Return the patient to the lordotic position with the neck and shoulder resting against the vertical. Supine position, adjust the body to the center of the clavicle. Respiration at the end of full. All right, what was the other one? All right, there's a difference there. All right, central ray is mid shaft of the clavicle. Cephalic central ray angulation can vary depending on the thickness of the patient. Thinner patients require increased angulation. Thinner patients require increased angulation. Everybody got the highlighter out. I just have a feeling that's going to be somewhere on that test. All right. For the standing position, we have a 15 to 30 degrees is recommended. For the standing lordotic position, it's what? Okay, so why is there a difference from standing or the lordotic? Huh? I can't hear you. Because the patient's so skinny, is what you said? If they're doing their lordotic, you've already added angle. You've already got 15 degrees. That's where they've taken that away. So if they can't do the lordotic, it's got more angulation, 15 to 30. If they have their lordotic position, it's 0 to 15 because you've already got them angled. So the angle can be anything. It can be the body, the IR, the tube, anywhere. So just when you see the word axial, you know that there's going to be an angle somewhere in this equation that we're doing, okay? So make sure you focus on the central ray for these different projections because I know it's on there. And this is always a challenge. So we know that the, what do we think about the supine? Can't do lordotic position on a table, can you? So it's going to be the 15 to 30. And that's the same as the what? Lordotic without standing, lordotic with standing straight without lordosis. All right, entering mid shaft, collimation 8 by 12 crosswise, suspend at the end of full inspiration. And the only one so far that was expiration was the straight AP. Yeah. Clavicle projected above with the ribs and scapula with the medial and end superimposing the thorax. Clavicle is horizontal position, including AC and SC joints. I'm going to get into the book a little bit more under evaluation criteria on page 258, third column. Entire clavicle along with the AC and SC joints. Lateral 2/3 of the clavicle projected above the ribs. Image analysis, image critique. She's going to have pictures of the clavicle. You want to see at least 2/3 of the clavicle projected above the ribs. If it doesn't meet criteria. No. So divide that clavicle into 3 parts. If 2/3 of them aren't above the what? Ribs, it fails. That's how you do image analysis for the clavicle. Because we're trying to project the clavicle what? Above the rib cage with the angles. Obviously with the straight, it's not going to be. We're not even trying. Right? We didn't even take the deep inspiration on the straight AP. But when we're doing the axial clavicles, the lordotic, anything with an angle, we are trying to project it above the rib cage. At least 2/3 are required to be above the rib cage. All right. Let's see. Clavicle is more horizontal in orientation as compared to that straight AP. So when you have an angle, instead of your clavicles being like this, like the natural, they turn out like this. That angle is going to take that little bit of angle of the natural curve and make it look like this. So it's a straight line. That's another hint for you in image analysis. If the clavicle doesn't have that natural look, then you're looking at, if it's straight like this, you're looking at something that has an angle. That causes those clavicles to be straight across the chest. They're not naturally like that. It was either lordotic or it was what? Angulation of the tube. All right. All right. Reviewing this, Miss Maya Brown. Ready? Look at me. Not your iPad. Okay, standing AP. What do you know about it? No, this is just standing. This is just a straight, we call it the straight and the upshot. That's what we talk in radiology. So now we're talking straight. So what was the only thing unique about it? Exhalation. The breathing was the uniqueness. They want you to exhale. That was the only thing mid-shaft. Make sure you get the whole clavicle. Then we go into the next one, which is going to be your axials. And there's multiple ways of doing it. So we're going to do one called with the what position? Lordotic. And what's the angulation? 0 to 15, because the lordosis is already added 15. So the patient can't do the lordotic position. So you do what? Add that 15 back to the 0 to 15. Now you're at 15 to 30. Table is going to be straight, and then it's going to be 15 to 30, right? Because we can't do lordotic on the table. Everybody good? Sounds easy. We're going to do much better on our image analysis. Yes. I've told you hints and tricks of how to do it. So I'm anxious. You know, I graded. I told y'all that, right? I graded everyone's. I just like to do that. I like to see where we're at. All right. All right. So this has got what? Definitely an angle. Look at this. What is it? What does it have as appearance? It's what? Horizontal. So that tells you right there it's with an angle. Because it should be what? Kind of way down here. And it's not. All right. AP versus AP axial. Can you see the difference? Look right here. You see how this is way down here? Look how you got a lot more rib above the clavicle. You got very little here. So that, and this is more what? Horizontal. This has got that angle, that natural angle to it. Everybody see that? Everybody good with this? Where's y'all's cards at? I still don't know y'all's names. I'm wanting to call on you, and how you can't think of your name. This and then right here.
Victoria.
Who?
Victoria.
Victoria Morris. See, I know that I can get the last name. I need that first name. Are you good with this?
Yes.
Tell me all about it.
So with the AP axial, it's going to have an angle because it's going to be horizontal, and with the AP.
And look, it has what? A little less this rib cage showing. You see right here? See this rib here? You don't see it here. So that's another indication. Less ribs is going to have the angle. All right.
And then with the AP, you have the natural angle of it.
Okay. So we have this.
Down into the rib cage.
Right. Very good. Very good. Ms. Shelton, you good? You want to just review everything we've covered the whole time so we can get out of here? If you can do it, I'll let you go. If not, you're gonna be here for the next 45 minutes. You want the pressure? No? Just picking. All right. So I think I have image evaluation and some practice coming on. I don't know how many more it is. Do y'all want me to keep this on that recording? Or you want me to stop this and throw that into whatever else I have left in the third? It's up to you. Stop? All right. Stop and start again.